afternoon or good evening, wherever in the world you're joining us from. And it's a real pleasure to welcome you to this special BMJ Innovations webinar marking our latest issue. But it also marks our new editorial team, new editorial board, and a relaunch for BMJ Innovations. My name is Mckimm, and I've the great honour of being the new editor-in-chief of BMJ Innovations as we start this journey. Thank you to everybody joining us, particularly those I can see from places like Hong Kong, where I realise it's just gone 10 p.m. We've got a packed session over the next 90 minutes or so. Coming up, we'll be hearing from one of the leading experts on innovation in vaccines, Jerome Kim. We'll also be hearing from some of you on the papers you've published in this issue, which was focused on innovations that were developed or matured during the COVID-19 pandemic. It was our biggest ever issue of BMJ Innovations, and there was some really impressive work submitted. And finally, if you're keen to publish your work in BMJ Innovations, we'll be talking more about the journal, answering your questions, and offering some top tips towards the end. So just a heads up, if you want to follow with the papers today, you can find them all online in our latest issue at innovations.bmj.com and on the registration page for today's webinar. So if you're new to BMJ Innovations, it's a peer-reviewed journal focused on emerging digital health, medical devices, and process and system innovations. It was launched back in 2015 and has been expertly steered by Prashant Jha as editor for the last 6 years. I'm going to tell you a little bit more in a moment, but first I want to introduce our Chief Executive, Chris Jones, who's going to tell you a little bit more about what our plans are.
Hello, I'm Chris Jones. I'm Chief Executive of BMJ, and it's odd to be doing yet another virtual introduction. I've been the Chief Executive of BMJ now just over a year. I joined the organisation in lockdown, and I continue to be in lockdown. I haven't spent a day in the office, and I've had very few opportunities of being able to meet my wonderful colleagues and, importantly, meet our wonderful partners. So I very much hope that as we begin to ease out of our lockdown here in the UK and hopefully more widely across the world, that I will get the chance soon to spend time in the office and spend time meeting people that we're doing some wonderful, wonderful things with. I really appreciate that this last year has been one of the most hardest, perhaps toughest, that everyone who works in healthcare has ever had to face. And that is perhaps made even more sort of significant as we pass the grim milestone of some 3 million deaths from COVID-19. However, at the same time, we have seen incredible innovation across the healthcare community, from the huge advances that we have made in developing vaccines quickly and the technologies associated to that, and to the significant rollout of telemedicine. And I very much hope that those types of innovations will leave a much more positive legacy over time on health, and that those legacies will have, genuine longevity, long after we've brought this pandemic under control, and that we can continue to take lessons, learnings, and insights from everything that we've done through the course of these last 18 months or so. Since the first issue of BMJ back in 1840, we've had to be at the cutting edge of medical innovation. And in 1847, for example, we published the very first reports on the discovery of chloroform and its role in anesthesia, which allowed complex surgeries for the first time. Joseph Lister's first papers in 1867 on antisepsis taught the world about how to prevent infections. And we went on to publish the research that linked the mosquito and malaria, and also that important first paper linking smoking and lung cancer. That's why we're really proud to be relaunching BMJ Innovations, particularly at this time as we emerge from the COVID pandemic. We hope and believe BMJ Innovations will be a new catalyst for helping to share new ways that we can collectively improve health outcomes. And that mission that drives BMJ is absolutely the heart of what we're trying to do here with BMJ Innovations. Create and improve the world to be a healthier and more productive place. On behalf of BMJ, I want to thank all the authors, some of which I know will be speaking later. I want to thank our editorial board for their wonderful guidance, and to our strategic partner, Wish, for its support. We look forward to showing many more significant milestones and innovations as the journal continues to evolve. But for now, I will say thank you for your participation. Thank you for your support. I wish you a wonderful day, and I very much look forward to meeting you in the very near future. Goodbye.
And as Chris said, thank you to all of you too. We've had 8 times the number of submissions this quarter compared to last year, and the largest ever issue. We've had 257 authors in total. I counted them manually myself. And we really appreciate your patience as we dealt with these extra papers and also the challenges of finding external peer reviewers during COVID. We're going to be introducing our editorial board a little bit later, but we've an amazing group of people that will be helping us on this journey to make BMJ Innovations hopefully become the leading journal in the field. We're going to continue to publish high quality research, but we're also introducing new types of papers. We've launched early stage innovation reports, which are designed to speed up sharing early ideas. And we've got some of the first authors and a peer reviewer of this paper type here today, and we'll be hearing from them very shortly. We'll also be launching a series of podcasts, blogs, and webinars to help inspire both existing and aspiring innovators. So do please give us feedback on what you'd like to see. We want this journal to be really shaped by you, our community. So pop any thoughts in the chat box, and do always feel free to drop us a personal email. We'll also be doing more deep dives. Earlier this month, we did our first, I hope, of many special supplements, which looked at innovations in Vietnam. We published a selection of papers and a virtual event looking at innovation there during the pandemic. So do check that out. It's on the homepage of the BMJ Innovations website. As Chris mentioned, BMJ has been working with the World Innovation Summit for Health, WISH, for a number of years. We've a shared vision of a healthier world through dissemination of evidence-based and best practice innovation. We're really pleased to welcome WISH as a strategic partner in BMJ Innovations. And here's a quick word from their chief executive.
On behalf of WISH, the World Innovation Summit for Health, I am delighted to be part of this relaunch of BMJ Innovations. Innovation is at the heart of everything we do at WISH, and I'm confident that we're at the start of a great collaboration that will build upon our existing relationships with the BMJ. A relationship born of a shared desire to build a healthier world that has already contributed to the publication of a number of evidence-based research reports for our 2020 Global Summit. The outcomes of which I very much encourage you to view on our new website. COVID-19 has placed an enormous burden upon us, but it has also forced us to be more innovative than ever before in addressing health challenges. It is therefore only fitting that the new issue of BMJ Innovations and this discussion today should focus on health innovation in the context of COVID-19. I look forward to our discussions today and to building a long and fruitful partnership with the team at BMJ Innovations in the months and years to come.
And if you haven't come across WISH before, do please check out their website as well at wish.org.qa. You'll find lots of useful reports and videos on healthcare innovation, some of those that we partnered with BMJ. So I'm going to introduce our associate editor, Helen Serrana, in just a few moments. She'll be talking through and presenting some of your work. But first, this week is World Immunization Week. We've been covering this across BMJ, so do please check out the papers, commentary and multimedia at bmj.com. Of particular interest to us at BMJ Innovations was vaccines. And at the start of this pandemic, a vaccine seemed 8 to 10 years away. And I remember this time last year, we were amazed that we might have one in 2020, never mind a whole host of vaccines at the end of last year. As part of a series this week, I spoke to Jerome Kim from the International Vaccine Institute about the progress in vaccine development and what this means beyond COVID. Jerome, thank you for joining us. If I could ask you first to introduce yourself and IVI.
My name is Jerome Kim. I'm the Director General of the International Vaccine Institute, an international organization located in Seoul, South Korea, that discovers, develops, and delivers vaccines for global health.
So Jerome, let's start by looking back to 2019 before COVID. What do you feel have been the big advances in vaccine development since then?
So I think that we've actually seen a number of things that worked. The Coalition for Epidemic Preparedness Innovations, which the United States was initially not a part of, but which was designed to basically develop vaccines around outbreaks, really was shown to work. The proof of principle is there. CEPI was out there with $1.5 billion of funding before the US Operation Warp Speed. They were able to jumpstart vaccine development, funding within a few weeks of the announcement of the sequence, the initial set of vaccines. And 3 of those vaccines actually are vaccines that we're hoping will go forward and actually be an important part of the solution to the problem. We've seen a proof of principle around RNA vaccines and adenovirus type 26 vaccines, chimpanzee adenovirus vaccines, vaccines that were able to get out there very quickly and were quickly shown to be safe and efficacious. So again, the initial proof that an RNA vaccine could actually protect people against infection or disease was done in COVID. The idea that a company manufactures its own vaccine has gone out the window. We have Sanofi, a French company, actually making another major vaccine company's vaccine. We have Merck stepping up to make the Johnson & Johnson vaccine. We have AstraZeneca talking to vaccine companies in Brazil, in India, and Korea to do the large-scale manufacture of their Oxford chimpanzee adenovirus vaccine. So we've seen vaccine manufacturing disseminated or distributed around the world, but importantly to companies that know how to make vaccines. Making a vaccine is not something to try, that you're going to hope that you get right the first time around. It's something that requires a significant amount of experience in the levels of quality that are necessary to produce a biological product that is safe and efficacious and can be shown to be the same dose after dose after dose during the manufacturing process. We've also seen vaccines move forward on an unprecedented timescale. I mean, a year ago, you asked me, how long does it take to make a vaccine? I'd say, well, probably 5 to 10 years. And now we know that we can, if we need to, make a vaccine in 11 months. And we can show that it's safe and efficacious. We haven't necessarily been able to show that we can make 10 billion doses of it in the next 11 months, but that's going to be the next set of challenges. We were able to very rapidly and very decisively collect information about breakthrough infections. Now, could we have done a better job at getting information about the variants and the mutant viruses? Yes. Will this continue to be a major challenge? Yes. But we have a system in place that will allow countries around the world to collect samples for somebody around the world to do the sequencing and to publish that data very quickly. So really important that we were able to do near real-time tracking of the pandemic and the viruses that are important in the pandemic. Safety. I mean, everyone thinks about AstraZeneca as potentially a failure because the safety signals were found. But we picked up safety signals that were 1 in 100,000. I mean, if you imagine a lightning strike has the chance of killing you at about the same rate sometime during your life. And yet we were able to pick up the safety signals from AstraZeneca and the even rarer safety signal from the Johnson & Johnson vaccine, which means that the safety systems that were set up to check for adverse events occurring at very, very rare frequencies after vaccination are working. Again, to assure people that our ability to both find safe and efficacious vaccines and then to understand what potential risks exist, if they exist, is also very important. And the final thing is COVAX. So, typically, and I'm going to use rotavirus vaccine because it's one of my favorites. Rotavirus vaccine is highly effective, highly efficacious. It was approved by the US FDA in 2006. It was approved by WHO in 2009 with a recommendation for use. In 2021, 11 years later, 60% of the world's children do not receive their 3 doses of rotavirus vaccine. Rotavirus vaccine production, 100 million doses a year. It takes a while for innovative vaccine technology in global health to get out from the high-income countries where it's invented to low and middle-income countries. With COVAX, 189 countries banded together, funded by primarily high-income countries, but also by the Gates Foundation, the Wellcome Trust, and others. And they are trying to get innovative COVID-19 prevention technology out to low, middle, and high-income countries in the first year of introduction. We've never seen that. Could they do it faster? Yes. Do we need a lot more vaccine manufactured quickly? Yes. But the mechanism is there. And, not to be a Pollyanna or an internal optimist, but we've never had a mechanism like this before, so that if we can make it work and if we can improve it, then we will have something that will be of benefit to everybody. And that's important. And the final part is, we had done a pretty good job, not a great job, but a pretty good job getting vaccines out to children who need them. So 80 to 85% of children around the world get their extended program of immunization, all the childhood vaccinations done. If we're going to make COVID work, the COVID vaccine work, we're going to have to not only vaccinate those children, but their brothers and sisters, their moms and dads, and their grandparents. That's going to be a major problem and a huge challenge. But if we get that to work, then we're going to be able to start to think about universal lifetime vaccination, vaccinating the older people against chickenpox or against pneumonia or against influenza. And those systems, once they're set up, are going to make a lasting contribution to global health.
So we've had an amazing amount of progress on vaccines, but do you think these advances will help us treat other infectious diseases that we've struggled with?
So 3 principal ways. The first is COVAX. COVAX is an attempt to get vaccine out to 189 countries around the world, high, middle, and low-income countries. If we can continue COVAX, if we can make it better, then this would be a mechanism to introduce pneumococcal conjugate vaccine to everyone around the world who needs it, to introduce HPV, human papillomavirus vaccine, to introduce rotavirus vaccine. Any new vaccine can be pushed through the COVAX mechanism, and hopefully then people will benefit from innovative vaccine technology sooner. The second and potentially very important development has been taking what used to be an extended program of immunization that vaccinates 80 to 85% of children around the world with the basic pediatric vaccines and turning that into a universal program of vaccination where we can now vaccinate older people against things that we know will threaten them, including pneumococcal pneumonia, variants of chickenpox that cause shingles, and influenza. So if we have this program that now vaccinates everybody, that provides a lifetime of vaccination protection, then we've made a major contribution to global health. And the last part is the scientific cooperation that went into the response and the development of new vaccines. Are we going to be able to sustain rapid reporting of mutations for not only for COVID, but will we then be able to detect other diseases more quickly? Will we be able to develop consensus around them as quickly? And hopefully we'll take the lessons learned from this and be able to translate that into better response to pandemic threats in the future.
So let's come to where we are now. What do you think are the biggest challenges over the coming months and years for the COVID-19 vaccine rollout?
I think access and equity are going to be huge challenges, and then also vaccine hesitancy. Now, access and equity is actually a very big and complicated issue. But at its heart, it lies the idea that until everyone is vaccinated, we're still going to be threatened by COVID-19. And we know that if the high-income countries take the first 2 billion doses of vaccine and vaccinate only their populations, that global COVID deaths will double, which means that global COVID infections will also double. That is a humanitarian crisis. It's jamming up hospitals. It's keeping people from other important medical care. There's also an economic problem. And the economic problem is also a very big concern for countries around the world. We think that, once we start vaccinating the populations in the United States, in the UK, and in Europe, that our economies will recover. But important modeling now done by the Brookings Institute and also by the National Board of Economic Review suggests that unilateral vaccination of just the high-income countries will cause a drag on their economies of $4 to $5 trillion. Now, and I don't necessarily read the things that the CIA and other intelligence agencies put out, but they've recently issued a national intelligence estimate that says unless there's equity, this crisis will continue and the economic consequences will continue. So again, you got it from The Economist, but you've also got it from the spooks. We really need to take care of this problem in an equitable manner. And then the final aspect has to do with vaccine hesitancy. And vaccine hesitancy is a huge problem, and it's going to contribute to more problems. And why do I say that? Vaccine hesitancy means that we will take longer to get to herd protection. And until we are able to control these huge outbreaks, I mean, India's having one, Europe's having one, the United States appears maybe to have thwarted or is turning the corner on a very large one, we're going to have the emergence of additional mutants. And if you imagine all the billions of dollars that went into developing vaccines, the last thing we want is to give the virus a chance to escape. So we have to vaccinate as many people as possible, as quickly as possible, in order, and to continue to use masks and other physical distancing measures in order to control the outbreaks, to keep the mutants from developing. So it's a race between our ability to vaccinate and distance and keep masks on, and the development of new mutants. And hopefully we'll get enough people vaccinated before the mutants are a real issue.
Many will say the COVID-19 pandemic caught us off guard. The countries that we thought had high levels of preparedness, like the US and the UK, were really hit hard during the early phases. Do you think the world is now better prepared for future pandemics? And what do we need to do post-COVID to prepare for the next one?
That's a great question. And so, I think that on the issue of preparedness, what we can't be, and as a person very interested in history, you can't fight the last war and hope to win the current one. And so we're going to have to put into place things that we know worked in this pandemic. We're going to have to improve our ability to develop diagnostic tests quickly. We're going to have a better ability to track and trace people who are infected and to isolate them when they are infected, because these are measures that help to control the pandemic before we have a vaccine. Then with regard to vaccine development, we've learned a tremendous amount. We know that we can develop a vaccine for a classical pathogen within a period of 11 months. What we haven't learned to do is to manufacture that in quality and in quantity. And we need a faster approval process. So, right now, one of the holdups is a number of vaccines are awaiting approval by the World Health Organization. To enter the COVAX facility, to be used and distributed around the world, you have to be approved by WHO. And unfortunately, some of the vaccines that are coming into WHO for approval are coming from regulatory agencies, which, while they are considered functional, are not considered stringent. So the WHO has to do a particularly good look to ensure that these vaccines that receive their stamp of approval actually meet the important regulatory standards around vaccine safety and quality. And that's taken a bit longer. So could we have faster access to vaccines from China or from Russia or from India if we had a better mechanism to move these vaccines along and ensure that they met the kind of quality that WHO insists on before it accepts a vaccine?
Jerome, thank you for joining us. It's always really great to have your insight. So we will be continuing to cover this paradigm shift in vaccines later in the year. We've got some special articles planned as well, so do look out for that as we move forward. Just a reminder, if you're posting comments in the chat box, please select attendees and panelists. Some of you are posting great suggestions for collaborations and reaching out to other people as well, but do select all other attendees so that everybody can see those. So now is the part I've been really looking forward to, which is hearing from many of you on the papers that have appeared in this special relaunched issue of BMJ Innovations. It was focused on the innovations that were developed or matured during COVID-19. And to tell us more about this special issue, I have the pleasure of introducing Helen Serrano, who's Associate Editor of BMJ Innovations. Helen.
Hello.
Can you hear us?
Yes, I can hear you. Can you hear me?
I can indeed, yes.
Fantastic. Yes, so I'm delighted to present this sort of compilation of chats I've had with authors over the last few days. Basically, I've done the time zone visits so that we didn't have to, and we could include as many people as possible on this webinar, and we've got some really interesting insights from authors. Now, I know some of those authors are here as well on the webinar, so please do take advantage of the chat box and ask them questions if you've got them, and if not, we'll pass them on. And also, of course, you can look at the papers on innovations.bmj.com if you're particularly interested in anything that comes up, which I'm sure you will be. Obviously, we only had a short period of time to talk to everyone, and we've got a few coming up. So just to say, the first video is one that was sent in, completed and produced for us by the authors brilliantly. And then that is followed by a series of different interviews that I've done over Zoom with people over the last few days, as I said. So yeah, that's all from me. It's been an absolute delight, and I'll speak to you again on the other side of this.
everyone. My name is Charlotte Bingaman, and I am a Senior Research Assistant at the Brown Lifespan Center for Digital Health. I'm here to talk to you today about the MyCovid Risk App that we developed. Our paper is called MyCovid Risk App, Development and Utilization of a COVID-19 Risk Assessment and Mitigation Application. Co-authors on this paper are Dr. Elizabeth Goldberg, Dr. Megan Ranney, Sadesha Pereira, and myself, Charlotte Bingaman. So the reason we created this app is because Dr. Megan Ranney and Dr. Goldberg, they are emergency physicians, and they were just being faced by questions from people and wondering, is this safe for me to do? Is it safe for me to go to the grocery store? Is it safe for me to go to my mother's house or to spend time in a backyard barbecue with friends? And people were really trying to understand at the beginning of this pandemic, what is my own personal risk score and what does all this mean? And so to answer this question, we created this app, and the way it works is it's activity-based, and we ask people for, where their location is, their zip code, and what happens is we pull from COVID prevalence data so that we can see which areas, are more risky than others. And then you walk through steps to show where you're going that day. So maybe, you're going to the grocery store or you are taking a walk outside. And what we found is when we were making this activity base is that there were many activities that we just couldn't cover. And so we created a build your own aspect of the app. So you could input, how many people are there? How long are you staying? Is it indoor or outdoor? And you would go through a series of steps that would help calculate your risk score. So then you receive your risk score, and there are also mitigation steps in the second half of the app. And there, you can choose if you're wearing a mask and what type of mask. Are you social distancing? Are you washing your hands? Are you going to reduce your activity time? And many others. And this leads to your final lowered risk score, just showing you your own personal estimated risk for becoming infected with COVID-19 based on the activity you plan on doing that day. Our findings from making the MyCovid Risk app is that we could take something from an idea in July of 2020, and within 3 months, we could create an app to spread a public health message at a critical time that over 1 million people across the nation as well as internationally saw. We noticed firsthand that we can make something at a relatively low cost with no marketing, just using social media to get the word out, and it was very well received. Where we go from here is that we are conducting a UX study to see how people use the interface as well as how it affected their behavior change. If you'd like to learn more about the MyCovid Risk app, please read our paper. Thank you so much.
So now we are in New York, and I'm delighted that you're able to join us. Would you like to introduce yourself and perhaps tell us about your co-authors and your paper?
Great, yeah. I'm happy to be here with you today too. My name is Sharon Ricken. I'm a general internist and the director of outpatient quality improvement for the Department of Medicine. And that's at Montefiore Medical Center and the Albert Einstein College of Medicine in Bronx, New York. Along with my co-authors, my colleagues, Dr. Eric Epstein and Dr. Anessa Ganlina, we wrote about our experience over the past year implementing inpatient e-consult program to address new challenges during the COVID-19 pandemic.
I think everyone who has worked in a hospital will know that getting consultations is a big part of the workload. What was the need and what did you find worked?
Right. So, there were two important problems that came up that were unique. The first is that the demand for consults increased tremendously. So even before the pandemic, there was a demand. For example, in infectious diseases, they were consulted about 400 times a week. But at the time of the patient surge, our first surge here in New York, the number of consults increased from 400 per week to 1,200 per week. So crazy increase in demand that we didn't know if we could really meet. And then the second challenge we found was the safety of our physicians and our medical teams actually going to see patients. So again, early in the crisis, we had a shortage of personal protective equipment. And as a teaching hospital, we were used to sending multiple team members in to see a patient. So the medical student would go in, the resident would go in, the attending physician would go in. And that no longer was feasible for us. Every time we saw a patient, we had to critically think who needs to see the patient face to face, so we could save PPE and we could also protect ourselves. And so those are the two challenges. And we thought back to our experience in the outpatient setting. Supply and demand issues aren't new, even in the outpatient setting or inpatient setting. And we, as many other institutions, implemented an e-consult program in the outpatient setting a few years ago to bridge that gap. So if I, as a primary care physician, had a question for a specialist that may not require an in-person visit, I could ask them an e-consult question and they would get me a response back, usually faster, saving the patient a visit, and it would help meet that increased demand. And so we thought, let's try to adapt that in the inpatient setting and see if it works for us. So with stakeholders, from our inpatient primary teams and specialists, we customize the program to address these new needs.
Right. And so what were the biggest challenges in implementing this program?
So the biggest challenge, I would say, is that we were doing this while we were implementing a whole host of new solutions, hopefully, to address the COVID-19 crisis. And so it was finding time to bring an interdisciplinary team together, which is vital for new initiatives, to do this while everyone was trying to figure out how to best take care of patients with a new disease, figuring out how to work overtime or be deployed to new settings. And that was our biggest challenge, really, is getting the team together to do this, and to do it in a way that we could evaluate it as we went on. So as someone who does quality improvement, it was important for me every week to look at the outcomes, to look how many people are we reaching? How many people are using this? Are people satisfied with it? Are there things that we can do to make the workflow easier? And so that's part of what we wrote about is that process of continuous quality improvement, to see, was this meeting our needs for those two challenges we outlined? And if not, how could we improve the program to make that happen?
Great. And so for readers around the world who might be working in similar situations right now, obviously the pandemic is still going on in many places around the world. What lessons can they learn from your experience?
I think the first is to think about what's gone well in the past. And that was really what we went to. We said, we have this idea that we've worked on before. Can we adapt it? Can we capitalize on this group that already has worked together before to make this happen, and understand your strengths, even in the time of crisis. And the second part, although it was challenging, is to bring that team together and make it a priority to talk about what's going on, what's going well, and what's not going well, and use that to reevaluate and iteratively improve.
I'd just like to thank you very much for submitting to BMJ Innovations, and I hope you will again in the future.
Thank you so much.
And now we're joined by authors from Texas and India and Chicago. So thank you so much for joining us. And Hemant, would you like to introduce yourself and your team?
Yes. So I'm Hemant Kulkarni. I work in San Antonio. I have my own company. It's called the M&H Research LLC, which is based in Texas. And my collaborators, one is in Chicago. He is Ambarish Atole. He is a co-first author on this paper, and he works with the Cook County Hospital in Chicago. And my younger brother, Anup Kulkarni, who is the first author of this paper, is based off in India, and he is an expert in computer vision and has a mastery over artificial intelligence techniques. He has his own company in Atomy, but I do also want to let you know that this paper was a part of our affiliation to the Latha Medical Research Foundation, which is a non-profit organization in India.
And so what was the title of your paper and what were the main findings?
The paper is, the old proverb that says that necessity is the mother of invention. In this case, it was a little bit of a tweak on that. The necessity was the mother of innovation. The innovation was that, when Ambarish and I started discussing, because he had direct patient contact during the first wave of COVID here in the US. And he said that one of the most important problems the hospitals keep facing is resources. We have lots of patients coming in, flooding the hospitals. And in the US at that time, the main problem of resource was ventilators. We just kept running out of ventilators. And we thought that if there is a way by which hospitals can, allocate their resources more rationally, that would be helpful. And since each and every COVID patient here, by protocol, undergoes chest X-ray, we thought that if chest X-ray taken at the time of admission can give us some idea of whether this patient will or will not need mechanical ventilation later, that might be useful for the hospitals. So that's what the paper is about.
Great. And how did you approach the problem? What did you find?
We collected data set of COVID patients of over 500 patients and collected all their X-rays at the time of admission. And then Anup, who is an expert in artificial intelligence, he tried to correlate those images, X-ray images, with whether the patient had actually needed mechanical ventilation or not. And so we did this supervised learning and tried to figure out whether the model, the artificial intelligence model machine, can predict the need for mechanical ventilation. We used some available architectures because this is not a big data set. And I would like to emphasize that the idea was not to come up with a development level machine learning algorithm, but to just answer the question, can this be done? And our answer was yes. Let me ask Ambarish to talk a little bit about the data set that we collected.
Yeah, thanks, Eamon. So we collected data on approximately 500 patients who were admitted to Cook County Hospital over a 3-month period. And every patient who was admitted for COVID-19 obviously got diagnosed using the PCR test and had a chest X-ray was done in the emergency room. Demographic and other comorbidity information was obtained from their medical chart. In addition, we also had 2 pulmonary critical care experts individually assess each available X-ray and give their basically clinical gestalt as to do they think that this patient would require mechanical ventilation during the period of hospitalization.
Okay, great. And then the machines came in to judge whether that prediction was able to be replicated automatically, pretty much. Is that right?
Yes.
Yeah.
Yes.
Okay.
But the machine had to be trained to do that. And that training was done by Anup. And let's have his views on how he did it.
Yeah, Anup, please.
Yeah, sure. So many times in healthcare today, especially, there's a lot of discussions going on around as to whether artificial intelligence has a place in healthcare, and people come up with some crazy scenarios, whether they will replace radiologists, whether they will replace pathologists and stuff like that. So I believe we are about 200 years away from that happening. The doctors have their own place, and there's a reason why they are trained for over so many years. And the way I look at how artificial intelligence and machine learning can be useful in healthcare is probably by helping in a particular clinical workflow, whatever it could be. I mean, in this particular case, we thought that this problem was ideally suited to using deep learning techniques, simply because we were not trying to say whether a patient has a certain X degree of COVID progressed or whatever, and there was no decision that was going to be completely and exclusively dependent on the prediction of the model. All the model was trying to do was help the medical staff, based on an admission level X-ray, predict if this patient may or may not need a ventilator later. And the idea was you just help the administration to kind of come up with a resource planning which can help them better manage their patients and not necessarily put ventilators on those who may or may not need, but put on those cases which definitely needed a ventilator support. So in that sense, I thought artificial intelligence should play a very focused role in healthcare and not necessarily try to solve and be a be all and end all kind of a solution for everything. And of course, we looked at a couple of deep learning architectures. One is, of course, the ResNet architecture, which has become popular in pretty much every computer vision related problem that one takes up, whether healthcare or outside healthcare. But we decided to go with a different architecture, which has had a greater traction in chest X-ray images, which is called the DenseNet architecture, which was first proposed by Professor Killian Weinberger in Cornell. And it was a small modification from ResNet, but what it did was it kind of helped improve the overall predictive ability of the model and also reduce the number of parameters that one needs to train. And the advantage of reducing number of parameters to train is that then you don't need a big machine or a cluster of machines to kind of train your network. And of course, there are a couple of other things that I should note before I pass it back to you, Helen. And the thing was, we were looking, as Ambrish said, the data set was from Cook County Hospital. In a way, our distribution of training and test data was also from a similar population. So I can't possibly just take it off and put it in a Bangalore hospital and say that this will start working correctly, because then we are talking of different distributions. We may have covariate shifts or domain shifts or whatever, because there will be different machines that are used to capture the X-ray. But we can do a little bit of tweaking, and the concept as it was proved with this data set can definitely be extended to other hospitals in their own data sets. So that's what we achieved, I think.
That's fantastic to hear, and thank you so much for describing your paper. Is there anything else you want to add?
Yeah, so the only takeaway that I would really want to emphasize again is that the effort was to try and answer whether this can be done. We're not there yet. But the novelty and the innovation in this is that you can use artificial intelligence to answer simple daily questions that are not usually included in clinical protocol, but you can give tasks like this to machines and help them help us.
Mm-hmm. Yeah, and I was thinking about the situation in India as we're recording is really one of resource planning and resources to treat being desperately short, and this is the sort of application that can help resource planning, not necessarily for an individual patient but across populations. Well, thank you very much, all of you, for joining me. I really appreciate it, and thank you for your submitting to BMJ Innovations.
Thank you.
Thank you.
Yeah, it has been a pleasure, and it's been a very pleasant experience for all of us publishing in the BMJ Innovations.
Speaking today to New Zealand. So please, would you introduce yourself?
Hi, my name is Samone Madanyan. You can call me Sam. And I'm a researcher and lecturer at Auckland University of Technology, AUT Auckland, New Zealand.
Fantastic. And what's the name of the paper that you've had published in this edition?
In this edition, we publish contact tracing applications, a review of technologies. The co-authors, Mohammad Nazaya, and he's doing his final master research under my supervision. And the other co-author, Farhan Mirza, is my colleague at Department of IT and Software Engineering, AUT.
So it's really great for us as a medical journal to have the real technical specialists writing for us. Can you just give us an overview of what the article is about and what you've explained?
Yes, basically my main research interest and the co-authors Farhan and Mohammed are health informatics or using technology in healthcare area. This is why we come up with the idea of writing this paper from technical perspective, but not too techy, so that can be understood by audience from other majors and areas. The main intention of having this paper is we came to conclusion that based on the available contact tracing, digital contact tracing applications around the world, we saw that the technology can really impact later on the types of data gathering, the types of information that we want to extract from raw data that can help governments and authorities to make informed decisions regarding the policies and procedures to somehow stop or at least lower the transmission of COVID-19. And this can be quite significant in terms of user involvement on using technology, plus the types of collecting data by considering all the privacy and security aspects and issues around the technology usage.
Great, thank you. And the main differences, or the differences you look at in your paper, relate to sort of the technical architecture. And I think a lot of people have heard of centralized and decentralized.
Yes.
That's one of the key differences, isn't it?
It's one of the difference. The other one is we have different types of technology. For example, we have Wi-Fi, we have GPS, QR codes, Bluetooth, all these technologies, and they can be implemented either using a centralized structure or decentralized structure. All of them may come up with a huge impacts on the types of gathered data, and also affect the privacy and security of the data gathering, because we understand that one of the reasons that probably some users are unwilling to use contact tracing application might be because of their uncertainty around the privacy and security. So in this article, we try to address them all, not really in a technical aspects, but also just to talk about, okay, what are the differences in security, privacy, and what are the major differences for the governments if they want to use all this data to extract information and knowledge and come up with something like preventative measurement to slow down the transmission of COVID.
Great. I think reading your paper, and I was part of the editing team working on it, my understanding is there's no one correct answer for every situation. It's a case of picking the right bits.
Yes, there is no right and wrong technology, at least at this moment. It all depends on the government or authority policy of gathering the data. Do they want to only identify those that have the virus, or they want to identify the close contact people as well, or they want to identify hot zones? By hot zone, we mean those areas with higher percentage of COVID-19 positive cases. It all depends on the policy and what they want to achieve by using this sort of technology. The other thing that probably it's worth to mention is we have some cases that governments come up with a combination of different technology to address the technology limitation, because there is no silver bullet in using technology for contact tracing. So each technology has their own sort of limitations or disadvantages. So by a combination of 2 or 3 different technology, they can overcome these limitations and come up with a more efficient and effective way of digital contact tracing.
Great, thank you very much. That's a sort of whistle-stop overview of the paper. I think we'll encourage people to read the whole thing for themselves. And I would also say there's some fantastic diagrams that you've put together that really explain the different architectures and the different pros and cons of the systems.
Yes, I hope the audience and readers find it useful.
Brilliant. And thank you for your time and getting up early to talk to me this morning.
Thank you very much. Thank you for having me, and it was a pleasure.
So now we're in America, in Connecticut and Boston. So I'm delighted to welcome you both. Would you like to introduce yourselves and tell us a bit about your paper, please?
Sure. So first off, thank you for the invitation. I think this is really exciting and an awesome way for us to showcase our work. My name's Janine Blake. I'm a PhD candidate at the University of Massachusetts Amherst with the College of Nursing and the Institute for Applied Life Sciences. I am a nurse, and the bulk of my bedside career has been spent in the intensive care unit. Dr. Karen Giuliano is my mentor at UMass Amherst, and since she's here, I'm going to let her introduce herself.
Yeah, so thank you. Janine and I have been working together since she entered the doctoral program. I'm an associate professor at the University of Massachusetts. It's a joint appointment between the Institute for Applied Life Sciences and the College of Nursing, and also the co-director of the very brand new, just formed Nursing and Engineering Center for Innovation, which we'll talk about a little bit later.
Do you want to just take us through briefly what your paper was about and the title and maybe the key points?
Sure. So our paper is called Extending Tubing to Place Intravenous Smart Pumps Outside of Patient Rooms During COVID-19. an innovation that increases medication dead volume and risk to patients. We were very fortunate to get to work with 3 co-authors who have pretty prominent roles in the IV medication safety space. So Robert Butterfield is an engineer and an IV smart pump expert. We also got to work with Tim Vanderveen, who's a pharmacist with expertise in IV smart pump safety, and Nat Sims, who is an anesthesiologist and the inventor of the IV smart pump dose error reduction system. So COVID-19 really pushed us to change a lot of practices and innovate in ways that we hadn't before. And moving IV smart pumps was a way for us to decrease PPE use and to decrease clinician exposure. So it can seem like an obvious decision, but once you dive into it, there's a lot of safety implications that we really have to think about. And this needs to come from the entire care team, which is part of the reason why we were so eager to publish in BMJ Innovations, because we really feel like this is a space that should have some recognition and some education across care areas and across providers. So a couple of the main issues that we see with moving pumps outside of patient rooms, despite all of the benefits that we as clinicians can gain from it, we really have to look at the patient safety. So there's a few issues related to the pressure that extended tubing can cause. It can cause decreased flow accuracy, but that wasn't the main point of this article. We really wanted to highlight another aspect that we really need to pay attention to when we're using this practice, and that is dead volume. So dead volume is the space or the volume held in tubing between the pump and the patient. And as you can imagine, when we extend tubing 10, 20, 30 feet, in order to move those pumps outside of patient rooms, that dead volume is significantly increased. And that can mean retained residual medication. As nurses, we're the first to really recognize when a therapeutic response is not met, right? We need to have a recognition of when that might happen, when it might not be met, when we expect it to. Those are all really important things for us to pay attention to. From the pharmacy perspective, dosage, concentrations, flush volumes for secondary medications, all of those things need to be considered when ordering and when dispensing the medication. And then ordering providers need to pay attention to how they're choosing to change rates, how they're choosing what venous access devices to be used. And we really wanted to start the conversation about that.
Yeah, fantastic. One of the reasons we're interested in publishing it is because it's a great example of a great idea, light bulb moment thing, but actually when you get to the bedside and you have the experience of people at the bedside, then issues become obvious around safety and practical application of things.
We also don't want to say that it's not a viable alternative, because it can be, but there's 2 things to consider: all the practical implications or the clinical safety implications that Janine mentioned, and also it's an opportunity for manufacturers to think about their technologies, how it impacts these safety, and to use that as material to help them innovate. So I think because it does solve some problems, but also creates problems, as most things we do.
So maybe now's a good moment to talk a bit more broadly about what your research group is doing.
Yeah, absolutely. So although this article is a review article, it's informed by work that we and our co-authors have collaborated on. But we have a big program of research coming up involving flow accuracy. And that's when I said the rate that the patient receives is different than what is actually displayed on the pump. And as an ICU nurse, it wasn't until I really started reading about, well, especially Dr. Giuliano's research, that I realized that as a nurse, I relied on technology.
And so nurses and engineers are actually remarkably similar. Both are trained problem solvers and both have to rely on innovation to find solutions. But despite these, they're in the natural setting, their paths rarely cross. So I came to UMass because we had the opportunity to really bring these 2 disciplines together in a very important way and to develop the center. And this is really going to allow nurses and engineers to really effectively and quickly test and develop innovations that require both of our skill sets. And the power of the nursing and engineering approach is really derived from this mutual collaboration.
So I'm really pleased to say we're joined by one of our peer reviewers, Claire Hackworth. So Claire, would you like to introduce yourself?
Hi, yes, my name is Claire Hackworth and I'm a nurse in Nottingham. I'm currently working in governance and I've got particular interest in error. Until a couple of months ago, I was working in critical care and I've been doing that since 1995. I also ran for several years a partnership with Hospital in Ethiopia, which is relevant because of the resource settings. You have to innovate a lot with equipment and repurpose things. So I was particularly interested to see this, and I've been working clinically during the pandemic. So it's very interesting to see how other people approach the challenges of this.
That's great. We don't usually do this with manuscripts, introduce peer reviewers to authors, but everyone has agreed that it's a great idea to have a bit of a discussion. So thank you all for agreeing to participate. Perhaps, Claire, you could say what your sort of first impressions of the first draft were and what suggestions you sent back to the authors.
Okay, so I was very interested to read it. It leapt off the page as an interesting adaptation to a challenge in practice. And I think, as you'd mentioned, Janine, it's one of those things, it looks intuitively incredibly appealing, but when you dig a little bit, all sorts of problems become apparent. And I thought you'd done a very good, clear job of breaking down where those problems lay, and particularly dead space volumes being a massive issue. I was also I very much liked the way you'd examined it from multidisciplinary perspective. I think that is so often lacking in papers, and it was just nice to read the inputs, the really important team members.
Thank you. I am really glad that came across. That was when we were outlining the paper from the beginning. I mean, that's really what we wanted to get across. So thank you. I'm glad that it did.
I think that really worked. There were so many points of error that were becoming apparent. And I think also in the background of the pressures of a pandemic, when people are dealing with increased pressures, probably reduced staffing, increased stress, it just seemed that there were so many points of error. I think I'd wanted you, when I read the manuscript initially, just to raise the profile of that and highlight that even more clearly. I was also interested if this is something you had experience of using in practice. It's not something I'd come across in the UK, and I was just interested to see had you used it and how it had worked for you. So I think I fed back a combination of those comments. I think I'd asked for a table just summarising the different risks from multiple MDT perspectives. I think that was a really useful reference tool for people reading the paper, and I was really pleased to see that in there.
And your comments were excellent. Every time we get reviewer comments, our work improves. And I loved your suggestion for a table. It's actually something that we've used in past articles. So I jumped right on that. I love that suggestion. I think we ended up adding a little bit more information about the use of moving pumps outside the patient rooms. But it wasn't something that I had done myself. And I added a little case study. I don't know if it was suggested by yourself or our other reviewer to add a case study example. I talked about my experience caring for a very, very sick COVID-19 patient and not moving pumps outside the patient room. And it gave me some understanding about how the decision could be challenging, because I absolutely can see how it could improve a workflow. But we really have to keep in mind the implications to patient safety, and that by mitigating those and by making informed decisions, we can decrease that risk, at least in part. And it's always a risk versus reward balance.
So Karen, have you got anything to add to the discussion?
Yeah, first of all, thank you very much. I've been writing now for quite some time, and I've really come to appreciate how important peer review is, because when you study something, you're passionate. Otherwise you wouldn't be studying it. And that passion easily can lead to tunnel vision and some narrow-minded views. And I found the peer reviews always help to say, oh yeah, should have thought of that. Oh yeah. And it's kind of funny because just recently I got a peer review that had, I think, more comments in the reviews than I actually had words in the paper. So it all doesn't necessarily get easier, even though I've been doing this for a long time. But you just take a step back, and just say, you know what, they're doing it for the right reason. And so at the end of the day, and plus you're gonna have a better piece of work for yourself as trying to develop your own scholarship. But even more importantly, you're going to have a better piece of work for your readers to disseminate this knowledge.
Great, thank you. Claire, have you got any other comments about the process of being a peer reviewer? Was it straightforward for you?
Because it's so relevant to my practice, I really enjoyed looking at the issues in more depth.
And you'd be happy to peer review again? That's my leading question.
Absolutely, yes. Yes.
Fantastic.
Thank you so much for the time and effort that you put into it, because it helps the readers, and again, it helps us a lot.
And it's not a small feat.
Well, thank you all so much for agreeing to talk to each other and with each other. It's been really great to get you all together, and thanks very much. So now we're going to go to Toronto in Canada. So would you like to introduce yourself and your co-authors and your paper?
Yes, my name is Don Redelmeyer. I'm a physician at Sunnybrook Health Sciences Center, as well as a professor in the Faculty of Medicine at the University of Toronto. And I'm joined by my co-author, Richard Thaler, who is an economist in Chicago.
Great. And your paper was based around nudge theory, wasn't it? Can you just tell us what the connection that might have with COVID and things around that?
Well, my co-author actually coined the term nudge, so it was a natural bridge. And the idea here is that there are many, many behavioral factors that are being used to fight COVID. It's not all about the vaccine, but instead it's what people do to and for themselves. Social distancing, wearing a mask. And in this study, we looked at the importance of making hand hygiene easy. It's not about more exhortation, it's about more convenience.
Okay, yes. I noticed the term sludge reduction in your key points. Do you want to just explain what that means?
Yeah, sludge is any unwanted aspect of a process that interferes with people doing the right thing, i.e. often there's a gap between intentions and actions. And it's not because individuals are foolish, but it's instead because something blocks them in the way. So making things easy is real important. One of the developments at my hospital, for example, is to make hand hygiene more easy by just installing lots and lots of dispensers all over the place, like outside of elevators, like inside of elevators, like staircases, like cafeterias, like parking lots. Whenever there's an idle time, put a hand hygiene dispenser right there.
Aha. So I think a lot of us will have seen that happening where we work, especially in hospitals, but sort of pretty much everywhere. And now in every shop, everywhere you go, there's a hand hygiene dispenser. So what did you do to nudge people to use these or make them more effective?
Well, but the problem is that there's so many of them all over the place. My hospital has more than 1,000, and each one of them has to be refilled at an irregular moment, all right? Some installations, they need to be refilled 2 or 3 times per day, others 2 or 3 times per month. So what we've done, as opposed to just monitoring them all, is labeled each one of them with a simple instruction: if empty, dial 4555, which just happens to be the extension of our local environmental services office here.
Right. And so that sounds very simple as an intervention. How do we know that it's been effective?
Okay, well, we do generate a lot of calls this way by Good Samaritans, and indirectly there are benefits. It shows that that the institution, anticipates anomalies, welcomes such calls, and takes the task of hand hygiene seriously. Whereas the converse, when you hit a hand hygiene dispenser and it's empty, that has an enormous disenchanting effect on the end user. It undercuts any goodwill that was there to begin with. Now, in terms of evidence, we didn't do this. We didn't roll it out as a randomized controlled trial, but we did send a medical student one afternoon to go and find 2 empty hand hygiene dispensers in the afternoon, and it took him more than 100 tries in 100 different locations. And then we sent the same medical student to our nearest rival hospital, less than 10 kilometers away. In like 100 attempts, he found 11 empty hand dispensers. So that's, at least some evidence that it's doing some good.
That sounds like as close to evidence as we're going to get in a situation where the health professionals are going to be pretty busy doing a lot of trials on a lot of important things. That's fantastic. I think it's a really great example of how the innovations that we talk about in BMJ innovations can be very, very simple, but also really important.
Yeah, I think so. It is extremely simple. Any hospital could easily do this as well. All it takes is a label maker, and we think it can do some good.
Brilliant. Well, thank you so much for joining me. It's been really great to talk to you and hear about your paper.
Great to talk with you too, Helen.
Okay, so now we are going to Bristol, and the paper that we're going to be discussing is about detecting coronavirus through a cough. First of all, over to you, Harry. Can you introduce yourself?
Hi, I'm Harry. I'm a first-year PhD student at Imperial College London under the supervision of Bjorn Schuller. I'm specializing in audio processing using deep learning, along with quantization representation learning. For the paper, end-to-end convolutional neural network enables COVID-19 detection from breath and cough audio pilot study. I am joint first author with Alexander Gaskell. Also, other authors are Panos Tizirakis, Alice Baird, Lynn Jones, and Bjorn Schuller.
Yeah, and we've got Lynn on the line as well. Lynn, so would you like to introduce yourself?
Yes, certainly. So I'm Lynn Jones. I haven't got a PhD, but I'm a medical doctor. Since 2002, I've been a consultant radiologist at North Bristol NHS Trust. But then I also happen to be Mrs. Lynn Kopok and Harry's mum.
Fantastic. So maybe let's go back to the manuscript and then talk a bit about how it came about. So Harry, do you want to describe the key findings and how you got there?
Yeah, so I think the main thing for this paper is it's a feasibility study into the potential for digital mass testing for COVID-19, specifically using a convolutional neural network to determine through recordings, which were recorded on people's everyday devices, such as phones and laptops, whether that person has COVID-19 or not. So it has great potential because from our initial studies, we're getting great accuracy scores, suggesting much higher than the lateral flow test. And because it's a digital test, it's essentially free, which is obviously another great benefit. One of the main points of critics of mass testing is that it costs a lot of money and it diverts key resources from other avenues for reducing the effects of the disease on the public.
And for the less experienced in computational science, convolutional neural network, can you give us a quick idea of what sort of field we're talking about?
I mean, looking at it from a high level, you start out with some information, in this case, an audio recording of a cough, which is just a series of numbers. And you have this convolutional neural network, which you can view as maybe a mathematical equation that through a number of steps throughout the convolutional neural network will tweak those numbers to something else. And as you pass through the convolutional neural network, the output will be a single number between 1 and 0. And this number can be treated as a probability score for the chances of COVID-19 or not. And so to train this convolutional neural network, the great thing about neural networks in general, artificial neural networks, is that they're differentiable. And that enables us to differentiate the whole network and work out which parameters in the network to tweak that would slightly improve its prediction accuracy.
Great. That's a really good explanation. I think it's probably all we've got time for without going too deep into everything else. But just quickly on the data you used to prove your concept, that data was something that was available online for anyone to look at, was it?
Yes. So colleagues in Cambridge have collected a huge data set by now of people coughing, breathing, and speaking, and it's crowdsourced. So people volunteer to be part of this data collection scheme. So the data, while it's publicly available, you have to approach Cambridge to get the approval to use it due to it being sensitive data information.
Great, thank you. So let's bring Lynn back in and talk a bit about how this paper came about. very rare that we have two members of the same family. Maybe lockdown had something to do with that. I don't know, Lynn.
Yeah, no, absolutely. I mean, I feel very privileged to have been able to be involved in this. I mean, we've been locked down together. We've been very lucky to have Harry home, and it's been a very special time, really. We've got a garden, and so when we have a break, we'll wander around the garden and talk about what we've been doing. So that's really how the collaboration started, because he would ask me the odd medical question about it. There is some evidence that the biological basis is because the virus affects the neurology of the person. And so early on, even before symptoms start, it starts to affect the coordination of breathing and speech and proprioception. And that ties in with the loss of taste and smell, perhaps.
Right, yeah.
So I think that's probably the basis for why this can work.
Right.
So I've found it really fascinating to be part of it.
So for me, we were just having one of our chats, and I was mentioning that when, let's say we have an audio recording of 20 seconds long, our network was just picking out, let's say, a 1 second clip. But it's only making a decision on a 1 second clip. And we're having a walk around at the garden, and my mum said, maybe you should increase that window, maybe to 6 seconds, because one of the effects of COVID-19 is maybe increased breathing rate, or when you're speaking, you have to speak quick and then breathe and then speak again and breathe, where someone who didn't have COVID you wouldn't notice these deep breaths. It would just be a continuous speech. So yeah, we increased the window size to 6 seconds, and we did see an improvement in performance. And at that point, my supervisor Bjorn just said, there's no reason why we can't bring Lynn onto the project officially, which was really exciting.
Brilliant. Well, we're really grateful to have received your submission, and we really enjoyed reading the paper, and I've really enjoyed hearing a bit about the authors behind the scenes. Thank you both very much for participating in this. Thank you.
Thank you
so much for the invitation.
Thank you again to all our wonderful, amazing authors. It's been a fantastic collection for this issue, and we really appreciate all the hard work that's gone into that as well. We do realize, and we've spoken about this before, that we realize submitting a paper to a journal can often be daunting if you're doing it for the first time or even the 20th time. And Helen and myself are really passionate about trying to make this process easier and helping where we can. So do please reach out to us. We're very contactable by email, and we'll be hopefully running further sessions in the future about how to get published and some tips as well. We'll be taking a couple of questions in a minute. So if you've got questions about BMJ Innovations or want some advice about getting published, please pop your questions or reflections in the chat box now. And do tell us whether you like this approach to video synopsis. We're a journal in innovation. We're going to try and do new things. We may not always get it right first time, but we hope we'll try new things to help get your message out to our readers as well. Before we dive into the questions, I want to introduce our editorial board. So we've got a great group of people who are joining us and helping us to steer BMJ Innovations. Hopefully it'll come up on the screen. If it doesn't, you can find that list on the BMJ Innovations website. We've got a great group of people from all over the world, from Hong Kong, from Singapore, from the UK, the US, Vietnam, who'll be helping to direct this journal. Very much we want to get you involved in as well. So throughout the next 6 months, we're going to be asking you for your advice about what you want from BMJ Innovations, your top suggestions for topics and ideas as well going forward. And we'll also be hosting 2 student fellowships as well. So our hope is that we'll be, at the end of this month, opening up for medical students, nursing students, healthcare professional students to come and join us and learn about running a journal. And you get to see how the decisions are made and be part of the editorial board that makes decisions there as well. So Helen, I'm watching the clock and I realize we're running very much out of time, but I'm going to suggest we dive in and maybe do a couple of, maybe just pick 3 questions that we have, and we can go through those, and we'll certainly pick up more in future webinars as well. Do you want to pick a question, Helen, first of all?
Yeah, one of the questions that came in that I don't know if you or I can answer, but I certainly think we've got authors that can. How can we make use of innovation for equitable distribution of vaccines when politics is involved? I really don't want to be putting you on the spot there, Ashley, but I do think it's a good opportunity to talk about the range of things we do publish. And one of them is a discussion paper we've got in this issue on using blockchain with vaccine passports. And I think innovation is right at the heart of what all the governments are looking at, and also the contact tracing paper that we presented from New Zealand really demonstrates that you can look at the technology, but and you can understand the technology pretty well, but you have to look at the politics and the science surrounding both of those issues. So whilst we can't answer that question, we know that there are definitely articles in BMJ Innovations that can, and we'd really like to encourage more on that.
I was going to say as well, there's actually quite a lot. We're hoping to do a series on innovations in vaccines later in the year, but actually this week the BMJ have been publishing quite a lot. We've got quite a few webinars as well. We had a discussion with the United Nations about the distribution chains as well, because a lot of the innovations we've seen in vaccines are not just about the vaccines themselves. We've seen, this huge paradigm shift in the development of vaccines with the AstraZeneca vaccine, with the mRNA vaccines, and as Jerome said, hopefully that'll lead on to other things that we can do. But actually, a lot of the challenges we faced was the politics. It's about the acquisition of vaccines. It's about the raw materials of being able to produce vaccines as well. So we've been doing a little bit of work on that. And, this week we've got a bit of a focus on vaccines. So there's plenty of content if you go to the BMJ website. And we'll be pulling this together, I think, later in the year into a collection, looking at all the aspects that we've learned during COVID and what that means for the future of other infectious and neglected diseases as well.
And so a couple of the other questions we've had have been really about submitting to BMJ Innovations, Ashley, and along the lines of what sort of topic areas do we cover and what's the impact factor? Why should people submit to Innovations?
Well, I think, as I sort of said earlier, we're trying to expand the reach just beyond clinical research. So I think the core part of the journal will always be high quality original research. We're in the process of going through re-indexing. In October, we'll be completing that process as well. So we will have an impact factor in the future. We don't at the present, but we're working towards that. But I think more important for us is, yes, we want to be a high impact innovations journal, but actually we also want to get your work out. So what we're going to try and do more of is making sure we're doing more distribution of your content. It's all fine published in a paper, but we want to get people to read it. And that's why, we've got a plan to do more podcasts, more videos. We'll be doing more social media. You'll see that we've got a Twitter account now set up as well. So we'll be kind of doing a lot of that work going forward. So our hope is that we want to encourage you to submit. We welcome papers across all areas of healthcare innovation. We are focused on medical devices. We're focused on digital health. We're focused on those system innovations, those process innovations in organizations as well to improve things. And we welcome all different levels. We've had students, we've had, top policymakers, we've had, Nobel Prize authors in this issue as well with Richard Thaler, and you heard from that project earlier. But really great projects across the board that we do welcome, and we want to be open. We've introduced early stage innovation reports, which I think are a new type of paper that we can take forward and allow you to publish work at that early stage, really sharing those ideas before you go on and do the proper clinical studies as well. So I think hopefully we're opening up that broader to a greater group, but still keeping that core focus on clinical research.
Yeah, that's absolutely right. And I think one of our challenges as editors, Ashley, isn't it, is making sure that we keep up those rigorous editorial standards of BMJ, and that we've really set ourselves a challenge there to do that in the innovation space, because obviously so many ideas are brand new that we finding the right peer reviewers for the right papers is sometimes a little more difficult than it can be on other journals. But that's very much our problem and challenge that we're really excited to deal with. So again, plea from us to anyone who's listening to the webinar, please do volunteer your ideas and your participation, and if you're asked to peer review, we're always really grateful, because it's those, as you heard on this webinar, it's those collaborations of getting people from different disciplines, from the front, from the bedside to the lab to the workshop, all together to make really good ideas even better.
And the two topics I think, Helen, we should mention as well, we're going to have a call for papers quite soon long-term conditions. So NCDs, we're having a special supplement that's looking at the innovations in those areas. And later in the year, we're going to be focused on frugal low-cost innovations as well. So those are really kind of looking globally at how people have done innovations that are really low costs. Many of those coming out of the global south, countries, but a lot of this can be applied to, Europe, UK, US, and other places as well. So that's a really fascinating issue. So I think, again, if you're not signed up to our email list, do sign up to that or follow us on social media. You'll get these call for papers as we go through the year, because I think BMJ Innovations is such a broad area that we'll have, each issue really exciting papers, but we also want to do a deep dive. And some of these deep dives will be in topics that, we'd love you to contribute to over time as well.
I think that's all from the questions, Ashley.
The bit I want to ask you, Helen, and I think that we can just kind of wrap up with a couple of final top tips for people as well.
Yes.
It's always a good thing to kind of end on. I don't know if you've got one or two tips for people, from your experience on BMJ Innovations and other journals for authors. What would be your top pieces of advice for authors submitting to BMJ Innovations?
Try us, I think, would be the top tip, is that we're always keen to get innovations. And actually, Ashley and I are very keen to hear. And if you've got an idea that you're not sure whether fits or not, just email us and we will definitely get back to you. And we're doing quite a few talking authors through what the best way to submit is. We're really excited about the early stage innovation report. We really want to encourage people to publish. If they're not sure whether they're ready to publish, the early stage innovation report is designed to be a way of getting peer review and getting editorial input into ideas early. So that would be my top tip, to just look at the remit for the different formats you can use for publishing in BMJ Innovations, and be prepared for some really good, rigorous peer review.
And our hope is that, Helen, we can run some more sessions during the year. We've done previously, getting published webinars as well. But we'll talk you through. I know it's really challenging often to, A, select a journal, then B, choose which article type you've got, and also never too sure whether your topic fits as well. So, do reach out to us. We just had a question there about, do we have a formal pre-submission process? We do. So if you go to the website, you can see all the different types of papers. We do ask you for discussion papers and our editorials to contact us first of all. And what we really do is sort of, in a way, justify why your paper is important. We've had more submissions in this quarter than we've ever had before in BMJ Innovations. We have a limited amount of space, so we as an editorial team have to decide which topics are most precedent for our pertinent for our users and our readers as well. So I think it's putting yourself in the place of the reader, I think, is probably the most important point. If you're a reader of BMJ Innovations, will this be novel to you? If there's stuff that's published elsewhere, it's probably less of interest to us. We want to be at the cutting edge. And I think as well, we are a specialist audience, so it will be people who are, aware of blockchain, aware of telemedicine as well. So we need that depth. I think the other challenge is that often people have that struggle between shallow and depth. You want to do a broad article, but we still want that level of depth as well. But I think putting yourself in the place of a reader and explaining to us why, as a reader of BMJ Innovations, this piece of work or this topic is really important to us. And I think you can see the format on our website of what we need, but we're very happy to have a discussion. So if you're never too sure, do drop us an email. We're very happy to kind of help you, to give you some guidance on which papers, and if it's not BMJ Innovations, which other journals that might be a good fit for your work as well.
Yeah, and that's something I'd add is, being part of BMJ as a publishing group, there's always a home somewhere for a lot of the manuscripts that are submitted. So we can help with that as well. But we're very happy to talk about any submissions coming in.
So Helen, I realize we're over time already, but I think let's leave things here. I think we'll hopefully have more of these in the future. If you like these, do let us know. If you don't like them, do let us know as well. It's another method for getting the chance to kind of speak to some of our authors, and we'll have some other guests and have some live sessions in future as well. So again, thank you to everybody who stuck with us for the whole 90 minutes. It's very impressive you're still here after all that time. we really appreciate your support, and hopefully we'll be doing more of these in the future. So do make sure you're signed up to our email lists, follow us on social media. Until then, thank you again, and best of luck with your future innovations.